Less than 5% of women diagnosed with endometrial cancer are asymptomatic. Approximately 80 to 90% of women with endometrial carcinoma present with vaginal bleeding or discharge as their only presenting symptom. Top 5 cancers detected in women: breast 32%, lung 12%, colon 11%, uterine 6%, ovary 4%. Of the gynecologic cancers, uterine is 49%, ovary 31%, cervix 13%, vulvar 5%, and vaginal 2%. Salpingitis can develop in 15 to 30% of women with inadequately treated gonococcal or chlamydial infections. Postterm pregnancy is a pregnancy that has progressed past 42 complete weeks or 294 days. Early decelerations are thought to represent the fetal response to head compression during the contraction, and the fetal heart rate inversely mirrors the changes noted during the contraction. Variable contractions are thought to be due to cord compression and can occur at any position in relation to a contraction. Generally, they have an abrupt onset and return of the fetal heart rate deceleration to the baseline heart rate. Late decelerations are thought to represent uteroplacental insufficiency. The deceleration of the fetal heart rate occurs at or after the peak of the uterine contraction and returns to baseline after complication of the contraction. Bradycardia is defined as a fetal heart rate that is less than 110 beats per minute. Oral contraceptives typically help with heavy menses, but are contraindicated in patients who are over 35 and smoke. Endometrial ablation destroys the endometrium and can create Asherman syndrome. Thus, it is reserved for patients who have completed childbearing. In a patient with non-tender plaques on vulva, if lesions have rolled edges, patient has poor health care or health management, and has potential palmar macular rashes, you should progress with dark field examination of the lesions to rule out treponema. Plasma osmolality is decreased during pregnancy. This increases the susceptibility to pulmonary edema. Tocolysis with terbutaline or other alpha agonists increases the susceptibility to pulmonary edema, especially with the use of isotonic fluids. Systemic vascular resistance is decreased during pregnancy. Women with chorioamnionitis are also more likely to develop pulmonary edema, but this is not usually the main cause unless a patient is in septic shock. Diabetic patients are at an increased risk for fetal macrosomia, although fetal growth restriction may also occur. The latter becomes a greater concern as in this patient, who has longer-term diabetes and vascular complications, such as retinopathy. Diabetics also have increased risk for polyhydramnios, congenital malformations of the cardiovascular, neural tube, and caudal regression syndrome. Preterm birth and hypertensive complications may also arise. Vulvar lichen sclerosis is associated with an increased risk of squamous cell carcinoma. The role of human papillomavirus infection or prior radiotherapy remains to be elucidated. Potent topical corticosteroids and skin care are the most successful therapeutics. Calcineurin antagonists have also recently demonstrated benefit. Follow-up for a molar pregnancy that has been successfully evacuated should be followed by serial beta-HCG levels to ensure spontaneous regression. Pregnancy should be avoided for at least 6 months. This can be accomplished with effective contraception, either OCP or other hormonal contraception. This is needed in order to prevent confusion in interpreting rising beta-HCG as either postmolar recurrence versus pregnancy. Molar pregnancy has been associated with folic acid deficiency. Therefore, women who have increased risk for molar pregnancies should ensure that they receive adequate folic acid supplementation. A complete mole can have a characteristic snowstorm appearance on ultrasound. With higher resolution ultrasounds, this will manifest as more of a grid or honeycomb pattern. This is due to the presence of multiple hydropic villi. This is a classic presentation for molar pregnancy, along with uterus that will be larger than expected based off of dating, as well as vaginal bleeding is nearly universal. Further, beta-HCG values are generally higher than values observed in normal pregnancy. Caution should be taken against the use of a single value to rule in or out a molar pregnancy. However, when combined with findings of enlarged uterus and vaginal bleeding, a beta-HCG value of greater than 1 million may be diagnostic. Further findings may include tachycardia from hyperthyroidism and hypertension from preeclampsia. These can occur due to the similarity in the alpha chain of the beta-HCG to TSH. Suction curettage is the standard management for molar pregnancies. Hysterectomy is an option in patients who have completed childbearing. However, morbidity of a hysterectomy is still considered greater than suction curettage. Methotrexate may become necessary if a patient develops post-molar gestational trophoblastic disease, but it is not a sole means of primary treatment. Determination of post-molar GTD will be determined by serial monitoring of beta-HCG. Suction curettage provides the definitive therapy in the vast majority of partial moles, greater than 95%. However, for complete molar pregnancies, beta-HCG levels will initially drop most often following D&C, but they can plateau and eventually rise in approximately 20% of cases. The risk of rising HCG following a partial mole is much less, approximately 5%. Choriocarcinoma is an exception to the rule stating that tissue diagnosis is a standard for diagnosis for malignancy. A positive beta-HCG in a reproductive age woman who has a history of a recent pregnancy, whether it's term, miscarriage, termination, or molar, is all that is necessary to establish a diagnosis. GTD is considered the most curable gynecologic malignancy, and preservation of fertility allows for successful future pregnancy. Women who have had one molar pregnancy have about a 1 to 2% chance of another molar pregnancy compared to women who have never had a molar pregnancy. Chemotherapy is very effective in treating the higher risk GTD diagnoses of choriocarcinoma, invasive moles, and post-molar gestational trophoblastic disease. However, chemotherapy is not indicated for treatment of molar pregnancy. SCC accounts for approximately 90% of vulvar cancers. Patients with this commonly present with a lump, and they commonly have a long-standing history of itching or pruritus. The chronic itch-scratch cycle of untreated lichen sclerosis or any other chronic pruritic vulvar disease is thought to stimulate the development of squamous carcinoma. The mean age of SCC is 65 years. With the diagnosis of vulvar squamous cell carcinoma, treatment should include radical vulvectomy and groin node dissection. The underlying cause, lichen sclerosis, can be treated with steroids, but would likely result in a needless delay in treatment of the malignancy. Trichloroacetic acid can be used as a treatment for warts as a result of human papillomavirus. TCA is not, however, good for vulvar intraepithelial neoplasia. For VIN, a proper treatment would involve either a skinning vulvectomy or CO2 laser ablation of the lesions. In a patient who is wishing to retain sexual function, CO2 laser ablation is going to be a proper approach, as a skinning vulvectomy can be disfiguring and often will include removal of the clitoris, which would diminish sexual function. Women who are on immunosuppressive therapy for conditions such as lupus, Sjogren's, dermatomyositis, polymyositis, or other connective tissue disease are at higher risk of HPV-related conditions such as condyloma or vulvar dysplasia, and as such require close surveillance. And thus the appearance of white multifocal flat lesions would lead to the possibility that this is development of dysplastic processes related to HPV. And further investigation with colposcopy and biopsy are indicated. Women who are on immunosuppressive therapy are also at increased risk for yeast infections, and treating a yeast infection is reasonable. However, in light of a negative wet prep, new clinically evident lesions should be treated as concerning for HPV-related dysplasias until proven otherwise. A pigmented lesion on the vulva that does not bother a patient and has other negative screenings is likely a melanoma in situ. Melanoma represents 5% of vulvar cancer. In comparison, squamous cell carcinoma is typically not pigmented. High-grade vulvar intraepithelial neoplasia may be flat and pigmented. Paget's disease is usually erythematous with a lacy white mottling of the surface. Condyloma lesions have a characteristic verrucous appearance. With lichen sclerosis, the skin appears thin, inelastic, and white with a crinkled tissue paper appearance. When vulvar intraepithelial neoplasia is the result of HPV, the classic presentation is multicentric brown pigmented papules noted in the perineum, perianal, and labia minora regions. Paget's disease of the vulva is an in situ carcinoma of the vulva. On presentation, the vulva is fiery red with whitish hyperkeratotic areas mottled on top without a distinct lesion. No nodularity or tenderness will likely be noted. Vulvar intraepithelial neoplasia is associated with HPV infection and smoking. VIN3 should be treated with local superficial excision. This excision should be a wide local excision. Risk factors for cervical cancer are all connected to HPV exposure and include early onset sexual activity, multiple sexual partners, a sexual partner with multiple partners, a history of HPV or other sexually transmitted diseases, immunosuppression, smoking, low socioeconomic status, and a lack of regular pap smears. Women with HIV have higher rates of cervical dysplasia and invasive cancer than women without HIV. Treatment failures or occurrences are more frequent, and disease severity correlates with decreasing CD4 counts. A pap smear should be obtained twice in the first year after diagnosis of HIV infection, and if the results are normal, annual surveillance can resume. If the pap results are abnormal, including cytology of abnormal squamous cells of undetermined significance, ask us, or low or high grade SIL, or squamous cell carcinoma, regardless of CD4 count or antiretroviral treatment status, should undergo colposcopy and directed biopsy. If a patient with an ascus pap smear has presence of infection / severe inflammation, it is appropriate to treat the underlying infection and repeat a pap in 4 to 6 weeks. In an entirely asymptomatic patient who has no convincing evidence of infection, and if they are an adolescent 20 years or younger, the ASCCP recommends repeat cytology in 12 months for an ascus result. In older women, management of ascus can be to perform HPV DNA testing, repeat cytology at 6 and 12 months following the abnormal Pap result, or colposcopy. If the HPV testing is negative, then cytology can be repeated in 12 months. If HPV is positive, or if repeat cytology at 6 or 12 months using the algorithm reveals ascus or higher, then colposcopy should be performed. If during a pelvic exam a white plaque or leukoplakia is found on the cervix, it should be biopsied directly or under colposcopic guidance as soon as possible, regardless of Pap outcome. Both CIN3 and CIS, carcinoma in situ, represent abnormal cells extending up to the full length of the squamous surface to the basement membrane, but not beyond the basement membrane. In cancer, the cells invade beyond the basement membrane. In microinvasive cancer, they invade less than 3 millimeters. When a Pap smear has high-grade or concerning results and a colposcopy with biopsies and endocervical curettage are read as normal, therefore resulting in discordant results, the next step should be to do a cervical conization. Cervical conization should also be utilized when an entire lesion cannot be visualized. This means that colposcopy will be inadequate and severe dysplasia and even invasive cancer cannot be confidently ruled out. Endocervical curettage has relatively low sensitivity, i.e. a high amount of false negatives, and therefore you cannot rule out endocervical disease based off of a negative endocervical curettage. Cervical conization is indicated if cervical biopsies show severe dysplasia, carcinoma in situ, or if a patient has positive endocervical curettage. Hysterectomy is the treatment for invasive cancer. On cervical exam, punctations and mosaicism represent new blood vessels on end and on their sides, respectively. Atypical vessels usually represent a greater degree of angiogenesis and thus usually a more concerning lesion. An ectropion is an area of columnar epithelium that has not yet undergone squamous metaplasia. It appears as a reddish ring of tissue surrounding the external os. Aceto-white epithelium can represent dysplasia, but in most cases is less concerning than the aforementioned vascular changes. New guidelines for cervical cancer screening include Pap smear initiation at age 21, regardless of onset of sexual activity. HPV 16, 18, 31, and 45 are linked to cervical cancer. HPV 6 and 11 are linked to condylomata acuminata and LSIL, genital warts. Histology of the cervix. Prepubertal ectocervix is squamous, and the endocervix is columnar epithelium. Where the squamous and columnar epithelium meet is called the squamo-columnar junction and is where 90% of cancers occur. Post-puberty, part of the endocervix everts, and due to the hostile environment of the vagina, the columnar epithelial changes to squamous, forming the transformation zone. The Bothian cysts, glands of the cervix during metaplasia, become trapped in squamous epithelium. HPV is a DNA virus that is incorporated into the host DNA, and if it is the correct regulatory spot, may transform the cells into intraepithelial lesions / cancer. Coilocytosis, variant particles within the cell producing damage. Classification can fall into atypical squamous cells of undetermined significance, low-grade cervical intraepithelial lesions, cervical intraepithelial neoplasia grade 1, and high-grade cervical intraepithelial lesions. We just discussed Ask Us, and there is Ask High Grade, which is Ask H. Glandular arises from endocervical adenocarcinoma in situ, AIS. Evaluation of abnormal pap smears. Colposcopy and biopsy will allow for direct visualization of the cervix and require visualization of the entire squamocolumnar junction to be considered satisfactory. Evaluate the cervical canal can be done by endocervical curettage or by cervical conization. Treatment methods include the ablative methods of cryotherapy, or freeze-thaw cycles. It's used mostly for CIN1. Excisional methods, cone biopsy, which is more appropriate for ACG, can include the cone biopsy or the LEAP, the thermal damage to the borders. If the margins are not clean, then repeat conization or have close follow-up. Cervical carcinoma. CIN will precede cervical carcinoma. The etiology of cervical carcinoma is HPV in more than 90% of cases. Symptoms may include intermittent spotting, postcoital bleeding, or dyspareunia. It spreads by direct invasion or by lymphatics. Staging is clinical. Treatment. Stage 1A1, conization or hysterectomy. Stage 1A2, radical hysterectomy with lymph node dissection or radiation. Stage 2A, radical transabdominal hysterectomy and lymph node dissection. Stage 2B and above, radiation therapy. Follow-up. During the first 2 years, 3 times per year, there should be follow-up with pap smears. Years 3 to 5, 2 times per year. Receive pap test and chest x-ray annually. So reviewing the essentials of diagnosis of cervical intraepithelial neoplasia. The presumptive diagnosis is made by an abnormal papanicolo pap smear of an asymptomatic woman with no grossly visible cervical changes, or you can diagnose by colposcopically directed biopsy. General considerations: cervical infection with the HPV virus is associated with a high percentage of all cervical dysplasias and cancers. There are over 70 HPV subtypes. 6 and 11 tend to cause mild dysplasia or are more commonly linked with genital warts, while types 16, 18, 31, and 45 cause higher grade cellular changes. Varying degrees of dysplasia are defined by the degree of cellular atypia. The Bethesda system uses the terminology atypical squamous cells of unknown significance, ASCUS, and squamous intraepithelial lesions with either low-grade L-sil or high-grade H-sil. HV testing of cytologic specimens may be useful for triage of atypia. Demographics. Cervical cancer is epidemiologically related to the number of sexual partners a woman has had and the number of other female partners her male partner has had. Long-term oral contraceptive users, smokers, and women exposed to secondhand smoke are at increased risk. Clinical findings, symptoms and signs. There are no specific symptoms or signs of CIN. Differential diagnosis is going to include cervical cancer, cervical ectropion, cervical ectopy, columnar epithelium on the face of os, common in adolescents, genital warts, cervical polyp, cervicitis, Nabathian cyst, or granuloma inguinal. Diagnosis. Laboratory tests include cytologic examination of the pap smear. Exfoliated cells are going to be collected from the transformation zone of the cervix and may be transferred to a vial of thin prep, which will be later transferred to the slide and fixed using conventional technique. Performance of conventional cervical cytology requires avoidance of contaminating blood, discharge, and lubricant. Diagnostic procedures include colposcopy. Viewing the cervix with 10 to 20 magnification allows for assessment of the size and margins of abnormal transformation zone and determination of extension into the endocervical canal. By applying 3 to 5% acetic acid, you can dissolve mucus, and the acid's desiccating action sharpens the contrast between normal and actively proliferating squamous epithelium. Abnormal changes include white patches and vascular atypia, which indicates areas of greatest cellular activity. Painting the cervix with a Lugol solution, which is a strong iodine solution, is also useful. Normal squamous epithelium will absorb the stain. Non-staining squamous epithelium should be biopsied. The single-layered mucus-secreting endocervical tissue will not stain either, but can readily be distinguished by its darker pink, shinier appearance. Biopsy, both colposcopically directed punch biopsy and endocervical curettage, are office procedures. If colposcopic examination is not available, the normal-appearing cervix shedding atypical cells can be evaluated by endocervical curettage and by multiple punch biopsies of non-staining squamous epithelium, or by biopsies from each quadrant of the cervix. All visibly abnormal cervical lesions should be biopsied. Treatment options: surgery. Conization of the cervix. Conization is surgical removal of the entire transformation zone and the endocervical canal. It should be reserved for cases of severe dysplasia or carcinoma in situ, CIN3, particularly those cases with endocervical extension. The procedure can be performed by use of the scalpel, the CO2 laser, the needle electrode, or the LEAP procedure. Biopsies should always precede treatment. Outcomes and follow-up. All types of dysplasia must be observed and treated if they persist or become severe. Because recurrence is possible, especially in the first 2 years after treatment, and because the false negative rate of a single cervical cytologic test is 20%, close follow-up is imperative. Cytologic examination. Repeat at 4 to 6 month intervals for up to 2 years for CIN2 or CIN3. Perform at 6 and 12 months for CIN1. Cytologic specimen HPV DNA testing can be done at 12 months for persistent CIN1. If repeat testing is normal, then routine cytologic screening can be resumed. Prognosis. At present, the malignant potential of a specific lesion cannot be predicted. Some lesions remain stable for long periods of time, some regress and others advance. Adequately treated CIN very rarely progresses to invasive disease. Prevention. Preventive measures include the following: regular Pap screening, limiting the number of sexual partners, using a diaphragm or condom during coitus, stopping smoking, and avoiding exposure to secondhand smoke. Regular cytologic screening with a Pap smear should begin at age 21, regardless of the age of onset of sexual intercourse. Should be done every 2 to 3 years during the period from 21 to 29, and may be done every 3 years for women 30 or older who have had 3 consecutive negative annual cytology tests. More frequent screening may be necessary in women with risk factors that place them at higher risk for CIN, such as HIV infection, immunosuppression, exposure to DES in utero, and previous treatment for CIN2, CIN3, or cervical cancer. After age 65 or 70, if there have been no abnormalities in the last 3 cytologic testing cycles, screening may be discontinued. Women with HIV infection should receive regular cytologic screening, should be monitored closely after treatment for CIN. The HPV vaccines, Gardasil and Cervarix, for patients not previously exposed to HPV, both can prevent cervical cancer caused by HPV type 16 and 18 Can provide partial protection against several other HPV types that cause approximately 30% of cervical cancer. Gardasil is recommended for girls and women aged 9 through 26 and can provide protection against genital warts caused by HPV 6 and 11. It is also recommended for men in the same age group. Because of the very low rate of abnormal pap smears in women who have undergone hysterectomy for benign disease, routine screening is not justified in this population. Essentials of diagnosis for cervical cancer. Some of the key features: increased risk in women with HIV and high-risk HPV types. Watery vaginal discharge, intermittent spotting, or postcoital bleeding may be early signs of cervical cancer. Cervical lesion may be visible on inspection as a tumor or ulceration. Vaginal cytology usually positive, must be confirmed by a biopsy. General considerations in cervical cancer. It can be considered a sexually transmitted disease, resulting in both squamous cell and adenocarcinoma of the cervix. They are etiologically related to infection with HPV, especially types 16 and 18. Women infected with HIV are at increased risk for HPV infection and cervical intraepithelial neoplasia. Smoking and possibly dietary factors such as decreased vitamin A appear to be cofactors. SCC appears first in the intraepithelial layers, the pre-invasive stage or carcinoma in situ. The demographics: pre-invasive cancer, CIN3, is a common diagnosis in women 25 to 40 years of age. Incidence of SCC is decreasing, while incidence of adenocarcinoma of the cervix is increasing. The clinical findings of cervical cancer. Most common signs are metrorrhagia, or irregular bleeding, postcoital spotting, cervical ulceration, bloody or purulent, odorous, non-pruritic discharge may appear after an invasion. Bladder and rectal dysfunction or fistulas and pain are late symptoms. On your differential diagnosis, you need to include CIN, cervical ectropion, cervical ectopy, meaning columnar epithelium on the face of the os, common in adolescence, genital warts, cervical polyps, cervicitis, Nabathian cyst, or granuloma inguinal. A positive pap smear is going to be a lab test. Imaging studies including ultrasonography, CT, and MRI are going to help with treatment planning. Laparoscopy and final aspiration are going to be other options. Cervical biopsy and endocervical curettage or conization are going to be some of the definitive diagnostic procedures. They are necessary steps after a positive pap smear to determine the extent and depth of invasion. Even if the smear is positive, treatment is never justified until definitive diagnosis has been established through biopsy. Staging are an estimate of gross spread of cancer of the cervix. The depth of penetration of the malignant cells beyond the basement membrane is a reliable clinical guide to the extent of primary cancer within the cervix and the likelihood of metastases. Treatment: carcinoma in situ, stage 0. In women who have completed childbearing, total hysterectomy is the treatment of choice. In women who wish to retain the uterus, acceptable alternatives include cervical conization or ablation of the lesion with cryotherapy or laser. Invasive carcinoma. Microinvasive carcinoma, stage 1A1, is treated with simple extrafascial hysterectomy. Stage 1A2, 1B1, and 2A cancers may be treated with either radical hysterectomy with concomitant radiation and chemotherapy, or with radiation plus chemotherapy alone. Stage 1B1 may be treated with fertility-sparing surgery that includes radical trachelectomy and a lymph node dissection with preservation of the uterus and ovaries. Stage 1B2, 2B, 3, and 4 cancers must be treated with radiation plus cisplatin-based chemo. Emergency measures that may arise. Vaginal hemorrhage originates from gross ulceration and cavitation in stage 2 to 4 cervical carcinoma. Ligation and suturing of the cervix are usually not feasible, but ligation of the uterine or hypogastric arteries may be life-saving when other measures fail. Styptics such as Monsol solution or acetone are effective, although delayed sloughing may result in further bleeding. Wet vaginal packing is helpful, and emergency irradiation usually controls bleeding. Follow-up for patients with carcinoma in situ who have undergone cryotherapy or laser therapy. Obtain a pap smear every 3 months for 1 year and every 6 months for another year. Complications that may arise. Metastases to regional lymph nodes occur with increasing frequency in stages 1 to stage 4. The ureters are often obstructed lateral to the cervix, causing hydroureter, hydronephrosis, and impaired kidney function. Almost 2/3 of untreated patients die of uremia when ureteral obstruction is bilateral. Pain in the back, distribution of the lumbosacral plexus is often indicative of neurologic involvement. Gross edema of the legs may be indicative of vascular and lymphatic stasis due to tumor. Vaginal fistulas to the rectum and urinary tract may arise. 10 to 20% of patients with extensive invasive carcinoma die of hemorrhage. What is the prognosis of cervical carcinoma? 2 to 10 years are required for carcinoma to penetrate the basement membrane and invade the tissues. Death usually occurs in 3 to 5 years in untreated or unresponsive patients. The overall 5-year relative survival rate is 68% in white women and 55% in black women in the United States. Survival rates are inversely proportional to the stage of cancer, with stage 0 having nearly 100% 5-year survival, 1A greater than 95%, 1B to 2A having 80 to 90%, 2B 65%, stage 3 with local invasion 40% 5-year survival rate, and stage 4 less than 20% 5-year survival. Prevention is regular pap smears, smoking cessation, and vaccination with Gardasil.